talk about anything since we have done the studies. Just let me just mention this one. You can see information is going to the visual cortex, and we are following the calcarine sulcus on the occipital lobe. Then you can see just inferior there we have got the primary visual cortex area 17, and then we have got the association areas. And I just wanted to mention something on this one. uh, How how is it that we have got the direct pupillary reflex and the consensual pupillary reflex? So we see that information that is coming from this eye and the information that is coming from the contralateral eye. So, so some of the information coming from here is projecting to the lateral geniculate nucleus. But don't forget also there is a bifurcation. Also the information that is coming from the other eye, the contralateral one, is also going to come to the lateral geniculate nucleus here. So what happens that now the fibers from the lateral geniculate nucleus can now project to the pretectal area. And then from the pretectal area, I've got fibers projecting to the accessory nucleus of the oculomotor. And that is going to go via the cranial nerve number 3. And then you are going to have the retinal ganglion. You are going to have these fibers which are passing through cranial nerve number 3. And these are innervating the oculomotor. So because you had fibers which were coming from the other eye and then fibers also from the ipsilateral eye, this makes it possible for the direct and consensual pupillary light reflex. So if you shine light in one eye, there can be also the dilatation of the other eye. We can start with this one. These are the questions that I saw in the from the papers. Abnormal color vision is 20 times more common in men than women because it is caused by an A dominant gene on the X chromosome, B dominant gene on the Y chromosome, recessive gene on the Y chromosome, recessive gene on the X chromosome. B and D are correct. Anyone that can help with this one? Okay. Are we all good, or there is someone that has got another option? Anyone else? Or we are good with that? Oh, okay. So this is the first question that we have. Auto Abnormal color vision is 20 times more common in men than women. What causes abnormal color vision? Okay. Hope the others can see. Are the others able to see the screen? Okay. All right. So we can move. So we've said it's a recessive gene on the X chromosome. A patient has no reaction of the pupil to light. Which muscle is damaged? Oculomotor muscle, ciliary muscle, dilator pupillae, sphincter pupillae, A and B. Anyone that can help? The muscle that is responsible for the dilatation of the pupil in reaction to light. Anyone? Sphincter pupillae. Okay, someone kindly explain. So, when you're reacting to light, a patient has no reaction of the pupil to light. Light causes the dilatation of the pupil. So, how is the sphincter pupillae damaged if there is no dilatation or if there is no reaction to light? Okay, thank you. That is the point. Is constriction and not dilatation. Thank you so much. Which of the following statements about the optical properties of a myopic eye is correct? Converging lens can be used to correct the optical defect. Image of a distant object is formed in front of the retina. Power of accommodation for near vision is greater than normal. Refractive power of the lens is less than normal. The far point is greater than normal. B. The image of a distant object is formed in front of the retina. So that just our anyone that would want to understand can understand. So here is the diagram. You can see if someone has got short-sightedness, myopia, they have got a difficulty in seeing things which are far, but they can see something that is near. So when you're looking at something that is far, you can see the image is forming before the retina. So to correct this mistake, you use a concave lens so that you can diverge the rays of light. Opposite for hypermetropia or hyperopia or for farsightedness, the image is behind the retina. So that is when you are looking at something that is near. But when you look at something that is far, your eyes are fine. To correct that mistake, you use a convex, so you would want to diverge the lenses quickly. Then you have got astigmatism that you can correct using a cylindrical lens. Okay, so hope we all agree there. Which one of the following is more descriptive of rods than cones? Remember, we're describing rods. Not located within the fovea, provide information about the color of the object, recover their sensitivity more rapidly after exposure to bright light, responsible for high visual acuity of the visual system, organized into on center of surround receptor field. Hey, thank you so much. Is there anyone that has got a different thought apart from A? I bet we are all good there. Thank you. So the fovea centralis only has cones. Which of the following is characteristic of the cornea? It represents the anterior portion of the tunica vasculosa. It is composed of three layers. It forms the anterior boundary of the posterior chamber of the eye. It is devoid of nerve endings. It is the anterior transparent portion of the tunic. Anyone that can help with this one? The anterior transparent portion of the tunic. Okay. Is there anyone with it? A represents the anterior portion of the tunica vasculosa. Alright. Let's hear first if there's any other option before we can get to say something about these options. For E, okay. Any other? Since we are a lot, let's give more options for people to be able to. And in case you want to explain your answer, please feel free. Any other? Okay, let's now allow for those ones to describe their option. Anyone? That's one to say something about their answer. Hmm. Uh, okay, it's going to, the choroid is going to be part of the tunic, the vascular tunic or the tunica vasculosa. Oh, so when yes, yes, doc. Sure, you can go on. Okay. Okay, so let's just look at it. So when we are talking about the layers of the eye, basically we have got the three layers. The outermost layer is the fibrous layer or the fibrous tunic, where the posterior 5/6, the majority is the sclera, and then the front, which is transparent, is the cornea. And then we're going to go to the second layer, which is the vascular tunic, the tunica vasculosa, which has got posteriorly, we are going to have the choroid, and then as we go anteriorly, can we see the ciliary body here? And then from the ciliary body, we're also having the more anterior portion, which is the iris, that is going to leave a space on the middle here, the pupil. And then the innermost layer, we are going to have the retina. The retina has got two layers also. It has got the neural layer and the pigmented layer. Yes. So, yes. So, so just another, oh, let me go back to the question. Just something else that we might be interested in knowing about the cornea. The cornea is of course transparent and it is avascular. There is no, it is not having any blood. But then for innervation, it is highly innervated. Yes, and it has got five layers, what is known as the corneal epithelium, the Bowman's membrane, the stroma, the Descemet membrane, and the cornea endothelium. So five membranes instead of three. So which one are we now going with? It is the anterior transparent portion of the tunic. That's true. Light is shown into the left eye of Jane Banda and elicits a direct pupillary reflex but no consensual reflex. Jane has a lesion in which of the following structures to account for the deficit: optic nerve, right eye, oculomotor nerve, right. Okay, they're even stating the side: optic nerve left eye, optic nerve right eye, oculomotor nerve right side, oculomotor nerve left side. Which one can we pick here? Oculomotor nerve right side. Is there another option? Is there someone that is wondering why the answer is C who wants an explanation, or we just move on? Just a moment. Uh, I just want to draw something on the screen so that it will be easy. Anyway, my board has disappeared. I can use the same picture that I'd included here. We can use this one. So we can see just that the other side of the eye is not shown, but we can see this fiber that is going here. So when information has come from, we can see this is the optic nerve. The information has come, it is going to the lateral geniculate nucleus there. Can we see that fibers are also projecting direct like that, going to the pretectal area, and then the information is going to the accessory oculomotor nucleus, and then it will be able to go this side. So what is this telling us? This is already telling us that as long as you have got information that has reached the pretectal area, right? The pretectal area, whether one of the eyes, the optic nerve, is not functional because of the information that has come from the other one, it will still stimulate the pretectal area. But then the difference is this: because from the pretectal area, the information is going to the oculomotor nerve. And then from the oculomotor, now you are having fibers going to the left and to the right. Meaning that even if you have got information that has come from the pretectal area, that is supposed to go through the oculomotor to make the eye be able to move. But for the fact that this oculomotor is not there, the information will still go through the oculomotor of one eye and then be able to make it be able to contract. And then you have got the pupillary light reflex. So for the side where you have got a defect, that is not going to be able to work. Let's say this oculomotor that is half here is the one that is being cut. It means that even when there was a stimulation at this point, this guy will not be able to work. But let's say it was the optic nerve. So if the optic nerve, we have cut this optic nerve at this point, what is going to happen is that if I shine the light in this eye, both this eye and the other eye that might be fine won't be able to constrict, because information already is not going to stimulate the pretectal area. But say this optic nerve is fine, but the optic nerve on this other side is not fine. So if I stimulate this guy here, even if the optic nerve on this side is not fine, it's not the optic nerve the other side that will be responsible for that pupillary light reflex, because I'll still be able to stimulate the pretectal area. The information will still go through the oculomotor to both eyes, and so we are going to see both the pupillary light reflex, the direct and the consensual. I hope we've gotten that. Hope I've done it. That's fine. Or maybe I've just lost people. Yes, doc. We are good. Okay. Okay. Hope we are all fine. Uve Uveitis is inflammation of the ovule tract. The following are the components of this tract. which ones are the components of the ovule tract? So there is C. Is there anyone who has got a different option? Okay. So it's the iris, the ciliary body, and the choroid. So this thing, the ovule tract, is basically that second layer of the elbow, the vascular layer, which is having the iris, the ciliary body, and the choroid. All are characteristic features of the cornea, except it's transparent, adequate blood supply, separated from iris by anterior chamber. Cornea ulceration may lead to perforation. Which one is exception? Option B. Thank you so much. Which what was supposed to be adequate if it was an option? Which option were we expecting? Innervation. Thank you. Innervation, yes. True concerning the macular lutea. It's located medial to the optic. Yes, yes. This one. Or adequate blood supply. Yes. Oh, so we were saying if there was adequate innervation, that would be a correct option. True concerning the macular lutea. True concerning the macular lutea. Is located medial to the optic disc, contains fovea centralis, which has both rods and cones. Mainly is supplied by the superior and inferior temporal retinal branches. Mainly supplied by the superior nasal and superior temporal retinal branches. Which one can we pick? Mainly supplied by the superior and inferior temporal retinal branches. Okay. Is there anyone with a different option? Anyone? Okay, in terms of location of the macular rhotia in comparison to the optic disc, where is it? It's on the lateral aspect. Yeah. Yes. So it's on the on the lateral aspect, and just that I didn't include the diagram for the blood supply. So are we? Pardon? Yes. Oh, okay. Okay. And then on the blood supply, doc, what do you remember? Okay. So since already we are saying that the guy is lateral to the optic disc, so expect it to be supplied by the temporal guys, isn't it? Because it's on the lateral aspect. The normal intraocular pressure is 10 to 21 millimeters of water, millimeters of mercury, 20 to 31 millimeters of water, millimeters of mercury. Which one are we going to go for? A. Is there anyone that wants to oppose A? Or anyone that wants to support A? We are all supporting, I believe. True regarding the lens of the eye. Has no capsule. Opacification leads to glaucoma. Contributes about 60 daptos to the eye. Rubella commonly causes congenital cataract. Pardon? D. Rubella commonly causes congenital cataract. Okay. C. Contributes about 60 daptos to the eye. Any other option? Okay. Okay. All right. So let me just say something about the power of the this is a lens. So yes, doc. Please go on. Okay. Thank you. Yeah, so for just two things we should, I don't know if it's water or something. We know the power of a lens is the reciprocal of the wavelength. So I've got a cornea and you have got a lens. So something that you can use so that you just don't forget is look at the cornea and look at the lens. Which one is more curved? So the cornea of the eye is bit of more curved, so the refractive power is more than the lens. So the refractive power of the cornea is 42 and that of the lens is 23. You can find their frequencies by simply taking the reciprocal of those numbers. So we remove that. And then opacification leads to glaucoma. How about opacification leading to glaucoma? Anyone that can say anything about that? Okay, thank you so much. So to opacify, it's basically to become cloudy. That really doesn't lead to glaucoma, isn't it? We know the glaucoma can be caused by either the closure of the angle or by simply having some mesh on the drainage site. Medial squint is caused by paralysis of which extraocular muscle? Medial rectus, lateral rectus, superior oblique, inferior rectus. The head and neck, anyone that can lateral rectus, anyone that wants to say something else, or who wants to agree, or maybe say something so that you just tell us what even the same medial squint means in case. Okay, medial squint is where your eye is pointed. Yes, doc, please go on. Okay, so we are saying medial squint is where your eye is facing the medial direction. And the reason as to why the eye would be facing the medial direction is because the lateral guy is not able to make that balance, right? So expect there is a problem. Rods and cones form synapses with which of the following cells? Amacrine cells, bipolar ganglion, molar, pigmented epithelium. Anyone? Bipolar cells. Just in case, thank you so much. For the sake, you can see you have got, this is our lens, this is the inside of the lens, and then this is the outside. And we know we have got a choroid, and then we have got the pigment layer, which is this one. From the pigment, now we have got the rods and the cones. The rods and the cones are now synapsing with these guys here, which are the bipolars, and then we are going to the ganglions. Take note that between the rods and the cones and the bipolar, you have got a connection there connecting them. Those are the horizontal cells. The amacrine cells are basically connecting these guys on top, which are the bipolars, and also these ganglion cells. This one, interruption of the visual pathway in the dash left optic tract causes blindness in the right visual field. Optic chiasma causes blindness in the nasal half of each visual field. Left optic radiation causes loss of the visual vision to the right. Occipital cortex causes loss of the light reflex. So which one has been correctly described? When you when there is a problem with the left optic tract, does that cause blindness in the right visual field? Optic chiasm causes blindness in the nasal half of each visual field. Left optic radiation causes loss of vision to the right. Occipital cortex causes loss of light reflex. Yeah, so there is A and B. Any other option? A, B. Okay. So there is A and B. Okay, let's do this. There's again. Yes, doc. Okay, plus C also. Okay, let's do this. Let's look at this diagram. So we can see what is on top here is representing the visual fields. You have got on the left side, you have got this is going to be, so this is going to be the left visual field, and then this is the right visual field. But the left itself has got the left half and the right half. Same with the right, it has got the left half and the right. So the right, oh, are others able to see my diagram? Maybe I'm running out of bundles or something. Okay. Yes, there is a diagram. Hope it has come, Doc. All right. So we can see that for the left, we are taking this as the left visual field. It has got the right half and the left half. So we can simply say the left visual field has got the this part that is medial is the nasal, right? So that is the nasal visual field. It's different from the nasal hemiretin. So the nasal visual field of the left visual field is going to go to the temporal hemiretin. And you can see now information is going to be taken like that. So this is telling us, depending with where we are, like on the optic chiasm here, if there's an injury, it means that the fibers which are coming from the medial or from the nasal hemiretiny. But then from the nasal hemiretiny, that information is coming from where? It's coming from the temporal visual fields. So it's the temporal visual fields that are going to be affected. But then that information is projecting first on the nasal hemiretiny and then it is going to go. So hope that is just fine, just to help us be able to now analyze the question. So let's start with a left optic tract causes blindness in the right visual field. Okay, let me just do this. Let me give me just a second. I just get a board so that we'll be seeing just on this screen. Okay, I'm going to show that question just in a bit. Let's discuss this one and then we go back to that one that the doc has just read. So here is our beautiful eye. So we have got this guy and this guy, and then now we can have our eye at this point and also this kind of eyeball. Okay, this guy is not sick. Is not having any problem. Okay, something like this. So our visual fields are on top. So looking at question number, option number one is saying left optic tract. Now we know the optic tract is gone. So we are going to have information. Let's say the one coming from this side, from from the temporal visual field on the left eye. This is going to be the right. Is going to hit at this point, and then the one that is coming from here is also going to come and hit at this point. What is going to happen is that these guys are going to flow in this tract here. I can allow me to put, can use the same color so that they are not disturbed. So we are having this structure like this. Okay, there. So what is coming from this side is coming to hit here, and then the fiber is continuing on the same side here on the middle aspect and then going to decassate. And then what is also coming from this other side is also coming to hit here, and then the fibers are still decasseting. But then what is coming from the opposite side, in this way it is hitting here and then it is not decasseting at all. Same way with this side, going like that. So here we are saying the left optic tract. So this is this guy here. What's this guy? Optic tract, optic nerve. So we have got optic chiasm here. We have got the tract here, isn't it? Hope I'm not pointing out the wrong thing. So A is the nerve and B is the tract. True? So here there is a lesion at this point, which is the left optic tract. So you can see for the left optic tract, it's bringing information coming from the nasal field of the left eye and also the temporal field of the right eye. Or simply, since this is the right side of the left eye and the right side of the right eye, we are calling these as the right visual fields. So left optic tract causes blindness in the right visual fields. That's true, isn't it? Hope that's, yeah. So, and I don't expect there to be another option that's correct. So this is going to be our option. Optic chiasm causes blindness not in the nasal half of each field, but the temporal. Because if we injure here, it means that we are disturbing the blue fibers. You can see the blue fibers are coming from the temporal aspects. Yeah. And then occipital and causing a problem with the light. The light reflex doesn't even go to the occipital cortex because the information is just here going to the pretectal area and then going to the oculomotor nucleus and then going back via the oculomotor nerve. So that means that's our portion. Let's go back to the question the doc is reading. Yes, please. Okay. Oh, I see. I see. It's supposed to be yes, they have, but it's supposed to be the right half. This is the right half of the left visual field, and this is also the right half of the other. But that is still the same because for each visual field, like this is the left visual field, it has got the right part and the left part. Oh, I see why. Yeah, it practically makes sense what the doc is saying because already the entire of this field here we are calling it as a right visual field. This is the left visual field. So if we just say right visual field, so we are meaning the entire of this eye. Hope we get what the doc is trying to say. Yeah. So we didn't even actually talk about. See, let's now try to analyze it. Perhaps it might be the answer because for that one, from what we are from mentioning, it means it can be just the opposite. So let me still put the eye there for each eye. Okay. So doc, we are still on this question. We've not yet concluded it. So the argument is this because if we say the right visual field, This entire part, this guy is known as the right visual field, but the right visual field has got the left half and the right half, which is the temporal and the nasal. That is why for this option, since it's just saying right visual field, it's meaning the entire of this part, but then it's not entire. It's supposed to be the right halves of each visual field, not really the right visual field as in this one, each eye. Yes. So we've seen here, yeah, I get you. We've seen here, here it is specifying this is the left half, this is the right half. So, but this is the right visual field. This is the left visual field. But each one of them has got the left half, the right half, the left half, and the right half. That's why for that option. But let's try to look at C. If C is not correct, then it means they were referring to what we are trying to think, right? So C is saying left optic radiation causes loss of vision to the right. So we are the fibers are projecting in the opposites. Let's put like this. This one is going here and they need to end up decasseting. Same with this guy who also come like so, decasseting. Can just put also this one going like that, but this guy is still going to the same side. Even this guy will still go to the same side. And then we are going to have the optic radiation, which are going all like that. And then even this one will go like that. So let's say this one is saying left optic radiation. So if there is a problem on the left optic radiation there, the loss of vision, we can see it is still going back to this half. That is the right side, isn't it? And still the right side here. But this is saying loss of vision to the. I think this one makes sense. Left optic radiation causes loss of vision to the right. But then they've just said right. I don't know if it is right half of the each visual field. So whatsoever we want to pick, we can just agree now because that's the same here. Mm, yes, doc. Uh, mhm, yes. So we do this. So if we cut this, it means that we have actually disturbed this region and also this region. Mhm. Yes. Mhm. Yes. Yes, yes, that's true. Yes. Yes. Okay. Yeah, yeah. We can see these guys are both on the right, so that is the same, so that is going to be homonymous. And because they are both on the right side, that is going to be right homonymous, and it is a half hemi. We are not seeing anopia. Anyway, I was just trying to think about just being right visual field, because just the word right alone itself. Mm, yes, yes, for the optic radiation. Thank you so much. So we go back to this question regarding the length of the eye. At option C, the lens contributes 60 doubt. Someone read 60. The lens, was that the length of the cornea? Hmm. Okay, maybe since they've said the eye, maybe they added for the lens and also for the cornea. Maybe they did add, because if you see the power for the cornea, it is around 42, and then the power for the lens itself is 23. So if you add those two, it's giving you like 65, which is approximately 60. Yes. So we can still maintain our option. Okay. In long-sightedness, objects at infinity cannot be focused sharply on the retina. Objects at the usual distance point are focused behind the retina. Ciliary muscle contracts more strongly to bring object in mid visual range into clear focus. The near point can be brought closer to the eye by the use of a biconcave lens. Which one can we pick? This is long sightedness where you are failing to see things which are short, isn't it? Or not things which are short, but things that are near. B. Objects at the usual near point are focused behind the retina. Okay. Yes, doc. Okay. So objects at the usual near point are focused behind the retina. Okay, we can, instead of me drawing anything, we can simply use what's already there. So you can see here in farsightedness, the object is being formed behind. That's for hyperopia. Difficult seeing close objects. So if the object is far, you can properly see, but if you bring it much near, the image is formed behind the retina. So we are good with B, everyone. Hope we are all good. Okay, let's look at the rest of. Let's start with option A. Objects at infinity cannot be focused sharply on the retina. Actually, for objects at infinity, those are the ones that you can see well. And we basically use 6 centimeters. So if, let's say, here is our lens for the eye, objects greater than 6 centimeters, you consider the fibers to be parallel. Same as though they are at infinity. So the fibers are going to be coming parallel, and then they will be able to converge just on the retina. But then what is happening is that when you come less than 6 meters, so let's say the object is now here, you can see first the light rays are going to be going like that. And the eye, let's say for example you have got short eyeballs, will not be able to converge the light properly. So converging might take more, it might take a lot for you to converge, and so end up converging way beyond the retina. So objects at infinity cannot be focused sharply. That's not true, because what's at infinity, that's actually what you are able to see, what is at a far distance. So this is true. And then for C, ciliary muscle contracts more strongly to bring objects in mid visual range into clear focus. So in this problem, in long sightedness, because you are not seeing, right? You're not seeing what is near. So what should happen? You need to focus the object to come in front of the at on the retina instead of behind the retina. And what you should be able to do is, when the lens you are using becomes more caved, it means that it's now be able to make your rays to bend all the more. So what should you do in this case? How can you make the lens to become more caved instead of more elongated? So to become more caved, what you want to do is, you uh, what we do is we relax the zonular fibers. But the relaxation of the zonal fibers is because of the contraction of the ciliary muscle. That is how this guy is going to come and then be thick like that. Because if the ciliary muscle relaxes, the zonal fibers are going to contract, and then we are going to pull the lens, and then it is going to become like very thin. It will be much longer. And when it is thin, it can't be able to reflect light all the more. But this option is saying ciliary muscle contracts more strongly to bring objects in mid visual range into clear focus. Parifet sungwa in mid visual range into clear focus. Then we'll ask a doc that is understanding properly that English to explain. Let's look at the near point can be brought closer to the eye by the use of biconcave lens. I think this is not even making sense. How is the near point brought closer to the eye by using a biconcave lens? Of course, we know when you are treating this condition, you are going to, besides what the body tries to do itself, you can use this lens which looks like this. What's the name of this lens? Not this lens. This lens will worsen the condition. The lens that you use is this one. Yes, you use a convex lens. Because it's two sides, you say biconvex. If it was just convex, it's more convex, is like that, but it's biconvex. That's the one you use, not concave. So let's go to option C. Anyone that is getting that nice English? Anyone that's getting the English on option C to help us? Okay, option C is not correct, isn't it? Whatsoever the English is saying. Okay, next question. Visual acuity is greatest in an area that contains mostly rods, the fovea centralis, the lateral edge of the retina, dark lighting condition. The fovea centralis, right? What is visual acuity? Anyone? What is visual acuity? Any doc to help us? Imagine it came just like that to write. Okay, the ability to distinguish 2 points. Is there anyone that has got something else? Or we move on? I think that's fine. So you being able to identify clearly the shapes, the ends of a point. Like for example, if you close one eye, you can see really the edges where you can see a finger. The cornea contains very few capillaries, is richly supplied with nerve fibers. Transparency is due to its cells having no nuclei, has an outer layer lined by tight junctioned columnar epithelium, is richly supplied with nerve. Thank you so much. Why is let's start with we know A is not true. What causes the transparency of the cornea? Why is the cornea transparent? Anyone? Okay, it's because of dehydration. The epithelium, the endothelium of the cornea helps in dehydration, and that leaves it transparent. And then this guy is not columnar. What is the epithelium of the cornea? Epithelium of the cornea. Yes, the same guy that is found in the esophagus, in the vagina, not the skin, because that's keratinized. A patient with left homonymous hemianopia will have a lesion in which part of the brain? Insular, frontal lobe, right parietal lobe, right temporal lobe. Lefty, homonymous, hemianopia. This is the guy that we are just from talking about, isn't it? It's just that that was right. This was right. But this one is going to be left, meaning that lesion is here. So where basically is the optic tract? I think that's the question. Where is the optic tract? Anyone? Oh, so that's the that's the same question that I'm just asking. In the parietal? Oh, you are also asking. Anyone that knows in which lobe? The temporal lobe. Mm, so meaning the answer is going to be this one, isn't it? The right temporal. Okay, so that is going to be that. And in which one of the following do axons carrying visual information synapse? Visual information. Medial geniculate nucleus, lateral geniculate, ventral geniculate, none. So it's LGB, lateral geniculate body or lateral geniculate nucleus. Regarding the retina of the eye, the following is true. Ora serrata demarcates the pigmented from non-pigmented retina. Optical retina is anterior while non-optical retina is posterior. Retina cells send impulses to epiphysis cerebri. In retinal detachment, the retina detaches from choroid. Anyone that can help us with this one? Any idea? D. Retina detaches from the choroid. Is there any other option? Okay. Which of the following is true about the visual pathway in the brain? The optic nerve carries information from both eyes. The optic tract carries information from the ipsilateral eye. Lateral geniculate nucleus is part of the thalamus. Primary visual cortex is located in the temporal lobe. Any C. Lateral geniculate nucleus is part of the thalamus. Okay. Which of the following is, which of the following is true about B? Optic tract. So the tract carries information from both the contralateral and the ipsilateral eye. Since that is after the chiasm when decussation has happened. Sorry. Oh, oh yeah, yeah. Yes, it's true. I think it's just incomplete. If it was that mathematics in high school where they used to ask what is found in A and in B, they told us if they say how many have got two children. If you have got three children, you also have two children. Unless if they say two children only. But I think for this one, since it's a one word only or one answer, we can pick the very best that leaves no doubt. Which of the following is true about visual acuity? So we've picked C here. Yes. Which of the following is true about visual acuity? It is highest in the fovea where there is high density of rods. It's highest in the periphery where there is high convergence of photoreceptors. Highest in daylight where there is a high activation of cones. It is highest in dark where there is a high activation of rods. Anyone? There's there. Anyone with a different option? We are good, right? Okay. Which of the following is true about accommodation? It is the process of adjusting the shape of the lens to focus on near objects. It's the process of adjusting the pupil size to control the amount of light entering the pupil. It is the process of adjusting the position of the eyes to align the image on both retinas. It is a process of adjusting the sensitivity of the photoreceptors to adapt to different light levels. There is A. We all go for A. Okay. Which of the following is true about color vision? Mediated by three types of cones with different spectral sensitivities. It's mediated by rods that can distinguish different wavelengths of light. It's mediated by a single type of cone that can vary its pigment composition. It's mediated by bipolar cells that can compare inputs from different photoreceptors. Option A. So remember, I've got three types of cones. Is there someone that wants to shine by giving us the names of those three types that respond to color vision? Yes, Doc, you can. Cyanopsin, iodopsin, porphyropsin. Okay, so with sight, That's where they end.